This is Going Under, Anesthesia Answered with Dr. Brian Schmutzler. I am Vahid Sadrzadeh, and we are brought to you by the Butterfly Network.
We are. All right, I'm going to let you in on something that's completely changed the way I practice. I've been using Butterfly probes for years. It's a portable ultrasound that plugs right into my compatible smartphone or tablet, so I can start scanning at the bedside in seconds. If you've used the older versions, or even if you're new to handheld ultrasound, let me tell you why this new IQ3 is a game changer and really impressive. First off, having an ultrasound that literally fits in my pocket means I can move faster, whether it's vascular access, procedural guidance, or just getting real-time insights from my patients. And the tech inside this tiny device is pretty incredible. Biplane imaging lets me see short and long axis simultaneously, which is great for procedural guidance, and honestly a great tool for learners. The new needle out of plane preset even shifts the scan plane digitally, so I can see the needle tip sooner, which makes a real difference when precision matters, and especially when I'm trying to put an IV in, honestly, out of plane.
Game changer?
Game changer. And the image quality, honestly, the IQ3 holds up against some of the high-end cart systems I've used. That's impressive for something this portable. So if you're looking for a device that supports your practice, I can't recommend the Butterfly IQ3 enough. And right now, they're running a special offer. You can get $750 off the latest IQ3. Check it out at butterflynetwork.com.
Appreciate Butterfly being our sponsor for a second consecutive year.
Yeah, and we've got some content coming out, too.
We do.
Yeah.
And hopefully we'll have somebody from Butterfly on
later
the
in
show
the season,
as well. You are wearing your Colts blue today. I see that.
I am. The hobbling Colts, we call them. The hobbling Colts.
5-1 is not too hobbling. Isn't that the best record in the league right now?
Tied for the best.
With
several others.
I don't know if anybody's 5-1.
There are several. Let me see what the old ESPN says. I think there are several that are 5-1.
I think there's a bunch that are 4-1.
I don't know. Let me look here. NFL standings. So at 5-1, 4-1 is Buffalo. 4-1 is Pittsburgh. 5-1 is Indy. 4-2, 3-1. 5-1 is Tampa Bay.
Wow.
Tied with Tampa Bay.
I'm just, okay, I'm not trying to be a negative Nancy here and pop a hole in your balloon. Pretender or contender? We're going to talk about medicine, I promise, in this podcast.
So they're going to win their division, I think, pretty obviously. Although
Jacksonville is right on their heels.
Yeah. So I think they win their division. I think they probably win one playoff game.
Houston's terrible Titans fired their coach.
Correct. So it's us and
Jacksonville.
And Jacksonville, yeah. And I think Jacksonville's overrated. Although we haven't played anybody, aside from the Rams, that are that good either. So.
And you lost to the Rams, even though you should have won that game.
Correct, because I don't even remember who the player was, but he dropped the ball at the half-yard line.
And then he had a holding penalty.
A holding penalty a couple plays later.
Nobody knows his name because he hasn't been heard or seen since.
Right. I'm surprised if he's still on the team. But this does relate to medicine because the Colts had two players who got injured before the game on Sunday.
Anthony Richardson was one of them.
Yes, correct. Using a band, he whacked himself in the eye and got an orbital fracture. The bone around the eye broke it, so that's
How
awesome.
hard do you have to hit yourself to get an orbital fracture?
How do I put this nicely? We don't want to alienate anyone, but how not smart, let's just put it that way, do you have to be to whack yourself in the eye with a band like that?
That takes some serious talent.
You've got like 7 physical therapists and trainers standing around you.
Just let them do it.
Just let them do it. Yeah.
Anthony Richardson experiment,
he's been a disappointment from day one.
Is probably over.
It's probably over. And
Riley.
Guess who that backup quarterback is? Riley Leonard. Notre Dame's own Riley Leonard. And then the other guy who got injured was a cornerback. I think he was a backup who was just doing some like shadow defense and in pre-op
shadow boxing
and pre-op.
In pre-op,
in pre-game warm-ups, no pads on or anything, and one of the ball boys ran out and ran into him and gave him a concussion before the game even started. So
come on, Colts.
And then you've got the week before, Mark Sanchez goes out and attacks some guy in
Indy.
In Indy, yeah, and that's what I'm saying. This is all an Indianapolis thing.
So Daniel Jones is injury prone.
Not as bad as Anthony Richardson.
No, that's true. I had predicted before the season started
he won't make it 16.
No, but the Colts
or 17 now
would turn to Riley at some point in the first quarter of the season, first half of the season, and I'm still on track for that.
Do you think he's ready?
No.
Okay. Yeah.
It's a different game.
Yeah. I don't think he processes it fast enough. I watched him a little bit in preseason. I don't think he processes it fast.
It's a different game. It's a different game.
And the NFL does relate to what we're going to talk about because every October they recognize breast cancer awareness and wear their pink socks and jerseys and gloves and all that kind of stuff. So today we're talking about
Breast Cancer Awareness Month.
Yes, correct.
And an important topic not only for women but for men as well.
Men get breast cancer too.
That's right. I'm gonna ask this stupid question, but breast cancer, cancers in general, are they all correlated to each other, or is it a different kind of, for lack of a better word, genome, or is it a different strain? Is that why you see breast cancer more often?
So not all cancers are the same. All cancers are the result of a mutation, a genetic mutation, right? That's what cancer is. It causes the cells to grow faster or out of control than they would normally, right? Every cell in your body, for the most part, except for your neurons, regenerate and create more cells. Basically, every cell in your body does that. So if the genetic mutation happens and those cells grow out of control, it becomes cancer. Breast cancer is not necessarily related to any other cancers. There may be some connection, although it's not fully elucidated what that connection is between breast cancer in women and prostate cancer in men that probably somehow relate. But otherwise, no. Other cancers aren't necessarily correlated with breast cancer. But breast cancer is the most common cancer for women in the United States. I'm just pulling up all the statistics here. I'm not a cancer expert. I am an anesthesiologist, but I do know some stuff about cancer. So breast cancer is the most commonly diagnosed cancer in women in most countries, 157 out of the 185 countries. Approximately 0.5% to 1% of breast cancers occur in men, so not totally uncommon in men. Breast cancer is the most common cancer among women in the United States. In 2025, it's estimated there will be 317,000 new cases, and 42,000 women will die.
Boy, that's a big number.
Yeah, huge. So a chance of dying from breast cancer is about 1 in 43 over a lifetime.
So there are places to go everywhere you live, obviously, and if you're, hopefully, if you're, we do have an international crowd, so I'm not sure as to the testing there, but, most places you go will have in the United States
a breast cancer clinic,
breast cancer clinic that will have a mammogram type of, and this is, right, like the medical brochures, right, and the marketing says, when you're in your 40s or your 50s. It's earlier, though, right? This should be an earlier test.
So just like colon cancer, breast cancer in women is occurring earlier and earlier. And we'll talk later about why we think that might be. But yes, it's occurring earlier and earlier. And we find this basically over time with all the cancers. They seem to be, and don't really know why, but really what the USPSTF, I think is what it's called, or what the organizations that recommend things say, they continue to decrease the age of screening for almost all cancers, but breast cancer. So I think right now they're saying 40 you should get annual mammograms. But I think, if you have any family history, and almost everybody does, you probably should start earlier, 30, 35. So,
and what is mammogram is able to detect
some breast cancers, not all.
Not all.
Not all. Yeah, there are some that it misses. So, but here's the thing. So if you catch a breast cancer early, there are a whole lot of things that you can do to prevent it from becoming deadly, right? Becoming fatal. If you catch it early enough, it's as simple as just taking out that one tumor. If it's maybe a little bit later than that, then there's, you can do mastectomy plus lymph nodes, because it goes to the lymph nodes in the armpit. So you take that out. Chemo, radiation, depending on what the genome or what the type of cancer it is. So, just like any cancer, the earlier you catch it, the better. Now, the reason they tell you not to get mammograms at, say, 25 is because there's a lot of false positives. So you don't want to go in, get a mammogram, expose yourself to the radiation, and then have something show up that's most likely just fibrous tissue. But then, all of a sudden, you're going down this whole path of getting a biopsy and all these kinds of things when it's probably nothing at a younger age. So again, right now they're recommending 40. I think that almost all women have some family history or risk factor. Probably not all, but almost all. So you could probably push that down to 35 or 30.
I just wonder, with breast cancer so rampant in this country.
Oh, yeah. All cancers, but breast cancer in particular, yeah.
Is it like this overseas? Like, are they seeing these numbers overseas?
Less common overseas, more common here. So, there's a few potential reasons for that. We test more than a lot of other countries, right? So you're finding more. And I think more women then, if you're finding more, catch it and then don't die from it. Or, there's a potential that you die with breast cancer, just like we talk about prostate cancer, right? More men die with prostate cancer than from prostate cancer. So, I think there are probably women in other countries who die with breast cancer because a lot of other countries have, their average age of death is 10 or 15 years younger than the United States. You may have a breast cancer, but if you're dying at 50, you're not likely that breast cancer is going to be metastasized and be the cause of your death. So that's probably one thing. But certainly there are behavioral, environmental, and other risk factors that are more common in the United States, right? So in the United States, we smoke more than most other countries. The number one, and I've said it a bunch of times on this podcast, the number one modifiable risk factor for almost every chronic and acute disease is smoking. So if you don't smoke, your risk of particularly breast cancer goes way down. Your risk of lung cancer, obviously, goes down. Your risk of bladder cancer goes down. Your risk of prostate cancer goes down. Your risk of skin cancer goes down. Your risk of kidney cancer goes down. Almost every cancer is reduced by not smoking or quitting smoking even. I mean, it doesn't put you back to a non-smoker level, but quitting smoking reduces your risk. So number one modifiable risk factor, if there's anything you hear from this podcast, don't smoke. Okay? Fair enough. So drinking is another thing. And this is more probably in the last 20, 25 years that the studies have shown this. Drinking more than moderate alcohol. And some would even say, some of the newer studies would even say moderate amounts of alcohol. So 1 or 2 drinks per week would increase your risk of getting cancer, and particularly breast cancer.
1 to 2 drinks
1 to 2 drinks a week probably has some increase in risk, although small.
And what about in men? I mean, like you
Same
hear
thing.
Same thing in men.
Same thing in men. Yep.
And is it genetic in men too, or is it more hereditary, or
Yep.
is it more?
It's hereditary in men as well. Yeah. So men who get breast cancer often have either a mother or father who had it, or a grandmother who had it. It's passed oftentimes through the mom or the grandmother, but sometimes through the father.
Cancer is just such an interesting topic, right? I mean, because
but it's not one thing, right? Cancer is not one thing. Cancer we broadly define as any proliferation or overgrowth of cells abnormally, but every type of cancer is significantly different. And even cancers, even types of breast cancer. And again, this is getting way out of my expertise, so I'm not going to go through all the 5 or 6 different types of breast cancer, but even the different types of breast cancer are significantly different cancers from each other.
How so?
So there are ones that are more invasive. There are ones that are less invasive. There are ones that are sensitive to certain chemicals and certain chemotherapeutics that aren't to others. So it's when you say something like, I have breast cancer, that doesn't give really a description. It's, do I have ductal carcinoma in situ? Do I have an adenocarcinoma? There's like a bunch of different kinds. Same with, let's say, prostate cancer, several different kinds of prostate cancer. Colon cancer. There's several different types of colon cancer. So
it's not just one.
It's not
type.
just I have breast cancer and everybody has the same breast cancer.
So when you've obviously been in the operating room for a lot of different procedures over the course of your career.
Correct.
Can you talk a little bit about the procedure for either taking out a tumor or even a mastectomy?
So there's a sort of a continuum of what they do for breast cancer. So probably the most benign, I say benign, not meaning benign, not cancerous, but sort of the easiest procedure they do is just a breast biopsy, or a partial mastectomy is the other thing they call it. So oftentimes all that includes is making an incision in the breast, finding where that particular tumor is, and taking it out. That's probably the most benign. We can do that with a numbing block and sedation. Not a huge deal. And oftentimes, if it's one of these early stage cancers, they take that particular tumor out, and the woman never has to do anything else. Okay, that's why
because it doesn't
detection,
spread.
right? It hasn't spread anywhere. Well, if you can pull out the whole thing, a lot of times there's no other issue.
Is that the most common that you're seeing?
Yeah, no,
well,
probably
I mean,
not.
for early detection.
Yeah, probably not. So a lot of that happens in a pure surgery center, which I don't really work at anymore. What we more see are things like either simple mastectomies or total mastectomies, right? So,
what is simple mastectomy?
So the simple mastectomy is just really taking the breast tissue. Doing the total, I think it's called a total mastectomy, is where they take breast tissue, they take some muscle, and then they also take the lymph nodes. So that's a big procedure, right? That's probably for higher level cancer, either cancer that has spread more or cancer that has a higher risk of spreading.
And you see men who preemptively choose to do that, even if it hasn't spread.
Because of the genetic marker, yeah. So there was a genetic marker discovered, it's probably been 30, 40 years now, called BRCA. And there's two types, 1 and 2. And I think they both predispose you to both breast and ovarian cancer. So a lot of women who are positive for BRCA1 and or 2 will have a prophylactic, or before you even have any chance of having cancer, mastectomy. Basically what that means is they just take the breast tissue out and put an implant in, or put some sort of other way to build the breast back up, and have a hysterectomy so that you can avoid the ovarian cancer. So total hysterectomy, where they take not only the uterus but also the ovaries. So
what is the survival rate of breast cancer?
That's a great
Did you have
question.
that in your stats?
Let me see. Let me go back through the stats here. Let's see. So mortality declines are more evident in high income countries. Okay, fine.
But because they're so different, I'm imagining, right? Because the types of cancer.
A woman in the U.S. has about 13.1% lifetime risk of developing an invasive breast cancer. So I guess if you say, if there's 317,000 plus another 60,000, call it 400,000, estimated that 42,000 women will die, roughly 10% are fatal.
Okay.
Yeah.
I mean, that's why early detection, that's why screening, that's why all of these things are...
Not smoking, not overly drinking, not drinking heavily, maintaining a good weight and a healthy diet, right? There are probably certain components in our food, and I don't think anybody's determined definitively which they are. Very likely some of the dyes that go in our foods, very likely some of the pesticides that go in our foods probably contribute to breast cancer. So healthy weight, healthy diet, exercise. For some reason, and nobody can figure out why, exercise is preventative for cancer. Even like 30 minutes, 5 days a week, 150 minutes a week is preventative for a lot of types of cancer.
Really?
Yep. Something about that changes your genetics. Exercise changes your genetics, or at least your epigenetics, the way that your genes interact with your body.
Is kind of interesting to me, because the way we are built as human beings, right?
Yep.
Isn't it to move? Isn't
Correct.
it to...
Oh, yeah, 100%, yeah.
Isn't it to... I don't know. Like, we're not built to be sedative. Is that a word? Like, you know what I mean? Like, what was the word I'm looking for? Sedentary.
Yes.
Thank you very much. Yeah, not
sedative. Yeah, sedentary. Right.
Sedentary. We're not built to be sedentary individuals.
Built to move. Yep.
We're built to move. So why does everything change when you do move? Why does everything, your health improves, your brain improves, your, the mental, the physical, why does it all improve when you move your body if we're meant as human beings to move?
So probably within the last 25 or 30 years, the scientists out there have really focused in on what they call epigenetics, or how your environment changes the way that your genes are expressed. So it's not just, DNA, I have my genes, it creates me, right? There are other things that happen, epigenetics. So epi means around genetics, around the genetics, from environmental, from all kinds of things, stress, internal stuff too, that can change the way genes are expressed. And so exercise probably modifies the epigenetic expression of many of these genes.
That's really interesting to me. I just think it goes to show like we are built as human beings to move.
Yeah. Yep. And if you think back to our ancestors when they were hunter-gatherers, right? They were moving all the time. They didn't sit at a desk all day long, or like I sit in an operating room, or I sit at a desk, or I sit, right? So we actually have to like cut out time in our day to go exercise. That's all they did all day long, right? They're running from tigers and running to shoot a woolly mammoth or whatever, right? I mean,
I think it just, I'm going down the rabbit hole a little bit with this one, but last night I was watching a video. I love historical videos. I'm kind of a history nerd, but I was watching a video that had to do with medieval times in Europe and even before that, right? Let's go pre-industrial revolution age, right? No light bulbs.
Nope.
It was expensive to have candlelight in your home.
So you just went to bed when it got dark.
You went to bed when it got dark. And think about it. It was 12 to 14 hours of darkness.
Certain times of the year,
right?
Yeah.
So you have nothing to light your home. I mean, even when it's cloudy out or, it's rain, you need something to light your home or it's dark.
Yeah.
They didn't have those things.
Yeah. So they slept a lot.
So they slept. And then they had something called two sleeps, basically.
Okay.
Where it was normal in medieval times to have two sleeps. So you'd go to bed like dusk.
Yeah.
You'd wake up
at dawn.
You wake up at like 10 or 11 o'clock.
At night.
Yes, just naturally. They didn't have alarms. They didn't have any of that stuff. They didn't have iPhone 17s. It was iPhone 17th century, right? So like they went to bed. They woke up at like 10, 11 o'clock, midnight naturally. Stayed awake. And then went to bed again at like 2 o'clock or 3 o'clock in the morning.
What they do in complete darkness from 10 p.m. to 2
So apparently it was just, maybe they did light a candle and it was like they wrote poetry or they had time to themselves.
They had lots of babies, so I'm sure that there were things that happened there.
Correct. Yeah. Time to reflect.
Yes.
So
what else are we going to do,
But it's amazing how the human body, right? I mean, but you look at the lifespan, how it's improved over time, right?
But that's mostly
Is that? I want to hear your take on this. Is that medicine?
Yeah, it's infection, right? So most people died of a bacterial infection of some sort
at 30.
At 25,
40.
30, 40, whatever age it was. So there's a bunch of books on this that are 100 years old, but basically clean water, so sewer systems or some sort of clean water, antibiotics, and antiseptic technique. So cleaning things off, like before you eat them, cleaning your cut off with something, cleaning before surgery. Those three things are why we have longer lifespans, right? So if you look at when those things all came into being, your lifespan increased dramatically. But I mean, what killed the majority of people until 100 years ago was number one, accidents, and number two, infections.
I just go back to Oregon Trail. Little Jimmy died of dysentery or whatever, right? Snake bite.
Although dysentery, I think, is a virus. But anyway, yeah. That's
sorry. Yeah. Getting into the weeds.
Yeah.
But essentially, the longer lifespan, right? And it all goes back to medicine, detection, can improve lifespan, can improve
antibiotics.
And now, what? Lifespan is 77, 78?
I think it's 78 for males and 82 for females,
Which is a huge number relative to 500 years ago.
Triple the age, probably.
Triple the age?
Yeah, probably.
I have to go down one more rabbit hole before we close this podcast.
So one more thing before you go down that rabbit hole. One other thing that reduces breast cancer is breastfeeding. So just so we're completely
Is it really?
safe. Yep. Doing.
Is it because of the hormones you generate or what?
Not sure.
I mean, I know
they don't know exactly.
That's interesting.
Unfortunately, as a male, you don't have that option.
Correct.
So you can do all the other things, but
You can't
not
breastfeed.
breastfeeding.
Speaking of medicine,
Yeah.
I do want to go down this rabbit hole with you
Okay.
for a couple
All right,
minutes
let's do it.
because it's just really it's fascinating to me,
Okay.
and I think our audience would kind of appreciate the rabbit hole. Our average lifespan is 70 to 80.
Mm-hmm. 75 to 85, let's say.
So I would like to know.
You're middle-aged, by the way.
I am
Over middle-aged.
over. Yeah, it's over. When you we've been introduced to things that keep us alive.
Uh-huh.
Okay?
Yeah.
So this is a relatively new as far as Homo sapiens go.
Yeah. Oh, yeah.
Okay?
Yeah, yep. Blip in time, for
A
sure.
blip in time, we've been introduced to medicines that keep us alive.
Mm-hmm.
Okay.
And prosperous, too. Like, not just alive. No, we don't just, like, limp through our...
Right.
Yeah. Okay.
The medicines that we are introduced to at times
Have side effects, yep.
have side effects and can be described as, okay, we're getting addicted to those medicines, right?
Yeah, maybe.
Or we're becoming numb to those
dependent
medicines,
on them,
dependent on the
yeah.
medicines, right?
Yeah.
So there will be a side of the population that says, well, medicine is not necessarily the end all be all, right? There are,
It kind of is if you have a raging bacterial infection. There's not a whole lot else besides an antibiotic
that can help you.
that can help you. Correct. So is it the end all be all of everything?
But
No.
is it some of these, this is where the rabbit hole comes in,
Uh-huh.
is there some of these medications that are causing some of these cancers that we don't know about?
Probably. Yeah. But again, if you have a rip-roaring sepsis where you have
to
take the medicine
Or you'll
because
die.
otherwise you'll die immediately. And yes, is there a chance that that's going to cause cancer 20 years from now? Yes, but it doesn't matter if it causes cancer 20 years from now if you die tomorrow because of the rip-roaring infection. So yes, and this goes back to the Tylenol thing, right?
But also cancer, I mean, chemo and
Yep.
radiation can also cause cancer.
cancers. Correct. Yep. And you have some experience with that, right? So this goes back to the Tylenol thing, though. Take the minimum dose that you need to take for the least amount of time and only for an actual issue. Crazy.
Crazy.
Crazy. Minimal
Crazy
dose,
talk.
minimal time. This is like first year medical school stuff. This is what they teach you. Don't give people a whole lot of something that they don't need.
Are there doctors out there that are over prescribing?
Well, it depends what medication you're talking about. What medication you're asking about.
I don't know specifically, but like
Opioids, probably in the past they have been.
you have experience with that.
Exactly. Antibiotics, probably. Yeah, because a lot of people show up, and we talked about this before too. They show up to your office, not my office, your office, but like a primary care doctor's office, and say,
Not our studio.
not
no.
our studio yet. Hopefully not. We're not giving out antibiotics here. And they say, I have a head cold.
Yeah.
I want an antibiotic. And you try to say, that's probably a viral infection. The antibiotic's not going to help you. And they say, but I want an antibiotic. And if you don't give it to them, they keep asking for an antibiotic. So I think there's a lot of physicians who prescribe antibiotics because...
Steroid?
Yeah, probably steroids.
Steroids,
too.
although antibiotic, or is it?
No, steroids are not an antibiotic.
But usually, like, if you have a virus,
they're an anti-inflammatory. So viruses and bacteria cause inflammation within your body. That inflammation helps kill those things, but it has the side effects, right? So you rev up your immune system to kill the bacteria or virus, but the side effects of revving up your immune system are that you get inflammation. So the steroids help with that inflammation. That's why it helps with like inflammation in your lungs from a urinary, an upper respiratory infection, not a urinary tract infection. Hopefully not in your lungs anyway. So we give steroids to people sometimes, particularly for lung issues, but also for some other things because it does reduce inflammation.
steroids better than opioids for treating.
Short term, yes.
Short term.
Yes. So long term steroid use does have a lot of side effects. Short term use, probably not. You give we call it a Medrol dose pack, right? Even though that's a branded name. 5 days worth of high dose steroids. You do that once a year, you're probably fine. That's probably not going to cause any long-term effects.
I would like to talk about at some point, not today, not today's podcast, but at some point I'd like to talk about pesticides.
Yeah.
Because, for a long time, I feel like as a nation, as just people on this planet, we use pesticides.
Correct, yeah.
And now we are finding out, and I don't know why now.
Yeah, there are probably some side effects, yeah.
Why now is the time that we're finding out some things about pesticides that are causing a lot of side effects.
So,
and specifically,
epigenetic side effects.
Parkinson's.
Yeah, probably true.
Cancer.
Yep.
What, again, this is a conversation for another day. I do want to hear what you have to say, but my dad, Parkinson's, was exposed to
farmer, right? Yeah.
Was exposed to pesticides.
Owned a farm, yeah.
Owned a farm.
Yeah.
Multiple farms.
Yeah.
Exposed to pesticides over the years.
Yeah.
This is what they found in Brazil.
Right.
Yep. With the banana farmers, plantains, exposed to pesticides for years.
So most chemicals are not without some sort of side effects. So if you look at and we'll talk about this in another podcast, but if you look at the history of pesticides, I'll have to look up all the specifics, but pesticides had effects primarily like DDT, primarily on other animals, not humans. And so the environmental lobby said, you're killing too many birds and bees and whatever else. You need to change the pesticides. Well, now they changed it to things that damage humans. So, I mean, had you just stuck with DDT, I don't know enough about it. I'll have to look it up. Had you just stuck with DDT, I think there would have been less of these things. Now, you're going to kill a lot of animals, but you're also not going to give a bunch of people cancer. So, was it worth it? I don't know. And we'll do a whole podcast.
Yeah, interesting.
Actually, it might be good to talk to. So we have a special guest next week.
Yes, we do. I'm very excited about it.
It might be good to ask him.
He's a farmer?
He's a farmer. Yeah.
Let's talk to him about it, because I'm really interested about the pesticides and the cause and effect. The correlation of disease and pesticides in human beings.
Yep.
That's for another time. But great conversation. You're not their doctor, but you are.
I'm a doctor, but I'm not your doctor. Ask your doctor if you have any questions or concerns. And don't smoke. I will say, if you ever ask me, did Dr. Schmutzler tell you not to smoke? I will 100% say yes. So you can take that one to the bank.
Take it to the bank.
There you go.
In his Colt Blue.
Colt Blue, yes. And watch out for bands in your eyes.
We'll watch out for those. And get tested. If you have questions or you feel something.
Get your mammograms, do your self-testing, self-checks.
All right. Well, we are brought to you by the Butterfly Network. This has been another episode of Going Under Anesthesia Answered with Dr. Brian Schmutzler.
See you next time.
I'm Vahid Sadrzadeh, and we'll see you in the next one.